Welcome to the Egg Whisperer Show, a program exclusively designed to promote reproductive health awareness and discuss fertility preservation options. Here is your host, the Harvard-educated fertility specialist, Dr. Amy.
She's known as the Egg Whisperer. Fertility expert Dr. Amy Abazadeh.
And you have yet another success story
Just launched by an East Bay fertility doctor.
Hi, everyone. Welcome to this episode of the Egg Whisperer Show. I am so excited to have Dr. Meivys Garcia on today's show. Hi, Dr. Garcia. Thank you for being our guest.
Hello, it's my pleasure. Thank you for having me.
So the topic of today's show is what's next? What to do when your frozen embryo transfer fails. And I'm so glad that you are our guest because you are an expert in this area. And you're going to definitely tell us exactly what our audience should know if they're in this situation. But before we get started, I would love to talk a little bit about you and tell our audience more about you. I'm going to read your bio first, and then I'd love to hear from you. So
Sure.
Dr. Garcia joined Markham Fertility in 2011, where she provides state-of-the-art, exceptional, and comprehensive care to her patients. She also is pleased to able to offer obstetrical care. Is that true?
Yeah.
Wow. I have patients that, they'd love if I were to deliver their babies, but that's amazing that you basically can help them from start to finish. That's impressive. Obstetrical care who have conceived through fertility treatment and offer services in English and Spanish. She did her 5-year subspecialty training at University of Western Ontario, which led her to pursue a 2-year Royal College Fellowship in Reproductive Endocrinology and Infertility with specialty training in minimally invasive gynecology surgery as it applies to infertility. And she has received numerous academic awards throughout her career, including the Governor General Academic Medal, and the list goes on and on. You guys can go to the website to learn more about her. But Meivys, tell us more about you.
My pleasure. So I graduated from medical school at the University of Western Ontario in 2004. And then, as you know, I did my 5-year residency. I know in Canada it's a little different from the US. So we do 5 years in Canada, followed by 2 years of specialty training, reproductive endocrinology and infertility. And I've been in practice for approximately 9 years, all at Markham Fertility Center, a place that I love and I consider everybody there my family. I'm very lucky in that I did continue my surgical practice as well with Markham Stouffville Hospital. They have a fantastic obstetrics and gynecology department there. I do follow my patients until delivery. I'm not on the call schedule anymore. So after my second child was born, I took a little bit of time to concentrate on my fertility practice. So I'm not up at 3 in the morning anymore delivering babies, but I do still follow my patients until they go for deliveries. And when there is a scheduled cesarean section, I'm still there to do their C-sections and welcome the babies into the world. It's usually one of my favorite parts of what I do. I'm also the mother of 2 boys. They are 7 years old and 3-year-olds right now. They both came from many years of fertility struggle. So that's something that has really changed the way I think and practice about fertility care.
Well, you have a wonderful approach to fertility care, and I really want our audience to learn more from your wisdom. So let's get started. Our topic is what's next, what to do when your frozen embryo transfer fails. So can you tell us, how do you deliver that kind of news to someone when their frozen embryo transfer doesn't work?
It's devastating, isn't it? I had 8 transfers and 2 children. So by doing the math, I had 6 of them failed. And some of them were biochemical pregnancies, some of them were straightforward negatives, some of them were miscarriages. So it's certainly something that I, unfortunately, not by choice, had a lot of personal experience with. So the first thing is that I always try to give patients a space. It's very common, especially as a fertility specialist, wanting to move on to the next step. Let's do the next transfer. Let's do the next surgery, the next thing. But I think it's really important to take a moment and acknowledge the loss, whether it is an egg or an embryo at day 3, at day 5. It is a loss. And I think it's really crucial for patients to take a big breath and say, I lost something, and to just hold the space for that. So usually when patient comes to me after a failure, the first thing that I talk about is, where are you at in your journey? How are you coping with this? What are your thoughts about it? You know, are we ready to talk about the next steps, or do we need to sit here and work on what just happened? And everybody's different. Some people, you know, have different coping mechanisms, but I think it's really important to take a big breath and acknowledge the loss and not immediately ignore it and move on to the next step.
Yeah. And when we were chatting a little bit before we started the show, you told me this really incredible quote that your mom says. What is that quote?
Right. So she says, failure is the admission price to success. And I think when it comes to IVF, that's really more true than ever, because the other thing that I talk to my patients about when you go through an IVF failure is that, you know, as a collective scientific community, we've been doing IVF for nearly 30 years. And in the span of scientific knowledge, 30 years is very, very little compared to other areas of medicine. So reproductive endocrinology is still a fairly young area of medicine, which means there's a lot that we don't know. And sometimes you have to try A to know that A doesn't work, and then you try B, and then you try C. And a failure is very devastating, of course, but it's also a piece of the puzzle. It's also information. It's not just a wasted time. It's not just wasted money. It's a clue that we can use to build on that and then get you where we need to go.
Wow, we need a t-shirt that says that. Failure is the admission price to success. And certainly they're all learning experiences.
Mm-hmm.
So what is the first step that you take as a fertility expert for your patients when they've had a failed transfer?
Yeah, the first thing is there's two main components. There is the embryo, there is the uterus. Well, there's three main components: the embryo, the uterus, and the body. So the first thing is to look at the embryo. So what was the embryo that failed? Was it a euploid embryo, which is a chromosomally normal embryo? And I can talk a little bit more about that. What was the morphology of the embryo? I know a lot of physicians believe that morphology is not important, and I do believe that there is some degree of importance to morphology. It might not be everything, and I know all of us have seen very poorly morphological embryos that go ahead and implant, but it doesn't mean it's not something that shouldn't be discussed. And whether the embryo was a day 3 or day 5 or a day 6 embryo. And then we talk about the possibility of whether or not we can improve on that. Can we make more embryos that are morphologically better, that are euploid? And this is a time-sensitive part. So even though the patient might be talking about transferring an embryo, we really need to say, okay, maybe you have one more embryo sitting in the freezer, but the time to make good, healthy, quality embryos is really now. And you will be talking about how to make more embryos as opposed to how to transfer those embryos. So it really depends on the individual person and what the circumstances are. If the person failed their first embryo transfer, but they have more morphologically normal euploid embryos in the freezer, then certainly I'm not going to be talking about making more than that. But because it's a time-sensitive issue, the ability to create healthy embryos is definitely something that I discuss with my patients at the time of talking about the first failed transfer.
Yeah. And I'd love for you to describe to our audience, why would knowing if an embryo is euploid or not matter? And what is a euploid embryo?
Absolutely. So a euploid embryo is, let's start back up a little bit. An embryo is a fertilized egg. So it's a combination of egg and sperm. And usually by the time that we know that this embryo is euploid, that embryo has gone from the day of fertilization, which is day 0, all the way until day 5 or day 6, at which point embryos are a blastocyst. So if a euploid embryo is an embryo that has gone through a process called pre-implantation genetic testing, which is basically the ability of taking a little sample of cells from the embryo and sending it to a laboratory to see if all the cells in the embryo are chromosomally normal or not. Now, this technique has come under a lot of controversy, and certainly there are some advantages and disadvantages. And like every test is not 100%, but it's certainly a test that has really changed the way that we see implantation failure and the way that we understand embryo competency and the ability to implant. So essentially, a euploid embryo is an embryo that has undergone the process of becoming a blastocyst. It's had a biopsy, and the biopsy has come back telling us that there is a very good likelihood that the majority of the cells in that embryo have the normal genetic material that is necessary to make a baby.
And what you also brought up, the different, day 5 versus day 6, How do you use that information to guide your patients if an embryo transfer doesn't work?
Yeah, so a day 5 embryo is an embryo that has become a fully expanded blastocyst 5 days after fertilization. And a day 6 embryo is an embryo that has become a fully expanded blastocyst 6 days after fertilization. So essentially, embryos that are day 5 tend to have a better implantation rate than embryos that had to take a little bit longer to get to that stage of development on day 6. So it doesn't mean that a day 6 embryo shouldn't be transferred. It doesn't mean that a day 6 embryo has no chance of implantation at all. But it simply means that it sort of gives us a little bit of a clue as to what the implantation potential from that embryo was in the first place.
Got it. So we talked a little bit about the embryo as your step 1. So what is your step 2?
Yeah. Okay, so before I go into step 2, I want to talk a little bit more about euploid embryo. So another thing that I talked to, and the reason I bring this up is because I had a miscarriage of a euploid embryo. So it was a biochemical pregnancy. So this really kind of opened up my eyes to sort of explaining. And a lot of time patients go, I don't understand how come it didn't work if it was a euploid embryo. So another thing that I explained to the patient is saying that you have a euploid embryo. It's a little bit like saying that your heart is normal. So if you go to the doctor and the doctor says, yeah, your heart is perfect, but the next day you are in the ICU because of kidney failure, it's because the doctor told you your heart is normal, but there's other organs in your body that your doctor couldn't have known by listening to the heart. So similarly, a euploid embryo has many pieces. It has the chromosome, which is what the genetic testing is for, but it has the mitochondria, it has the nucleus, it has receptors, it has the machinery of cell division. It has tons of other pieces that are also very important for the very complex process of implantation, cell development, and turning into a baby. And those other pieces are not assessed by the testing saying that the embryo is euploid. So even though knowing that an embryo is euploid significantly increases your chances of implantation and live birth, a euploid embryo could still be an embryo on itself that doesn't have the right energy and other material that is necessary for implantation.
That's a wonderful and
acknowledge that.
Yeah, that's a wonderful and extremely helpful explanation. And I'm going to have this show written up for folks because I think it's important for people to even print out and read and share with their friends, because that's an experience that a lot of people have had. And I don't know that anyone has had a physician really explain it in such a beautiful and easy to understand way. And thank you for that, because I'm going to have to take it and steal it from you. So thank you.
You are welcome. It's all yours to share. I want every patient to benefit from this. My patients.
Good. So what do you do next? So after we, talking about the embryo, what is your next step as a fertility expert?
So next we'll look at the uterus, and the uterus has 2 parts: the anatomical part of the uterus and what we call the lining of the uterus, of the endometrial lining. So from the anatomical part, it's important to determine that the cavity of the uterus where the embryo is going to implant is normal. By normal, I mean that there are no abnormalities there, such as a septum, or scar tissue from like a prior miscarriage or a prior pregnancy. We want to make sure there's no polyps or fibroids, because all of those things basically distort the endometrial cavity and makes it more difficult for the embryo to implant by decreasing the amount of healthy surface area where an embryo can attach and implant. So one way to determine that is doing a saline sonohistogram that allows to separate the walls of the uterus and look inside. An ultrasound alone is usually not sufficient to make that diagnosis of what's going on inside the cavity of the uterus. So it's really important to have those tests done. And generally for my patients, I like to do that test myself, because it's really great that I obviously trust my colleagues very, very much, but I like to look at the actual picture myself rather than just looking at the interpretation of the picture done by the radiologist. So I like to perform those tests myself or with my other colleagues in the clinic so that I have the picture available to me. And then another way of assessing the uterine cavity is by looking inside the cavity directly with a procedure called a hysteroscopy, which is a procedure that I know in the States is done in clinics, but in Canada it's done in the operating room, where we put a camera inside the uterus and directly look at the cavity and determine if there's any issues there that need to be addressed. So that's from the anatomical side of the uterus. Now, from the point of view of the lining, then we want to know that the lining of the uterus has two things: the right thickness, actually three things: the right thickness, the right appearance, and the right receptivity. So the thickness is, we want to know that it's at least 0.7. We want to know that it's a triple layer at the time of the ovulation or at the time just before you start the progesterone supplementation. And we want to know that it's receptive, and the best way to determine the receptivity of the uterine lining is by doing a test called endometrial receptivity test. And this is a test where we do a biopsy of the lining of the uterus, and we send it to a company that analyzes the different markers for receptivity and tells us exactly at what point in the cycle the lining is most receptive. We have known for a very long time that the window of receptivity is very narrow. It's usually about 24 hours, and sometimes it can be abnormally displaced in a cycle. So it is important to determine what is the optimal time for embryo transfer.
So as far as the protocol you use, I'd love to hear a little bit more about your special sauce. Yes. And how you get patients ready for their transfer. And if you're gonna, let's say, do the endometrial receptivity test that you mentioned, what kind of protocol do you use for that? And also, what's your favorite progesterone? We want to know all those things.
Okay, all right. So there are two protocols for embryo transfer. There is a natural cycle and there is a medicated cycle. My preference is for a natural cycle. However, not every patient is a candidate for a natural cycle. So to have a natural cycle, you need to have regularly ovulatory cycles. So patients who have polycystic ovarian syndrome, patients who have premature ovarian failure, those are patients that are not a candidate for a natural cycle simply because they don't have the dependable normal rise in estrogen, LH, and own progesterone production. So in patients like that, we do have to do a medicated cycle where we supplement them with estrogen and then progesterone. And I'll tell you in a moment about my progesterone. But with the natural cycle, there's something about trusting Mother Nature with this process. I do find in my experience that we get much better pregnancy rates with the natural cycle. It means that patients don't have a lot of flexibility. That means they have to come to the clinic every day and they cannot plan their cycle at all. It's basically waiting, doing blood work every day, finding the right timing for ovulation, then doing your ultrasound to look at the lining, and then the transfer have to be done at a specific time based on when the ovulation. So there is zero flexibility in terms of planning your life around the transfer. And trust me from experience, it's difficult to do that when we all have busy lives, but I do believe that it's the most optimal protocol for embryo transfer. Again, it's not every patient is a candidate, and when that is the case, then we use the medicated cycle. So my favorite progesterone is the progesterone in oil injections. It is it's a lot painful to use, and believe me, I still have the bumps. I still have my battle scars, so I understand that it is very painful to administer, but there was a very recent study, I'm sure you're familiar with that, looking at pregnancy rates with the use of progesterone in oil, and it seems to be a lot better than the old formulations of progesterone that we used to use. Technically speaking, in a natural cycle, you're making your own progesterone, so it might not be as critical to use progesterone in oil in that situation, but for a medicated cycle, when there is zero production of progesterone on your own, I think it's crucial to be able to use the most available form of progesterone, which is the progesterone oil injections. So that's my favorite.
Thank you. So you've basically talked through several things. You talked to us about thinking about embryo quality and if more embryos should be created. You talked to us about the protocol and progesterone, looking carefully again at the uterine cavity. Can you talk to us about strategies to thicken the lining if that's an issue?
Mm-hmm. So two things. There have been some studies suggesting that if your lining is receptive with the ERA, and if your lining has the triple layer appearance, the thickness of the lining may not be as crucial or as critical as we once used to believe. So that's one part of that. And sometimes I say to patients, listen, we cannot get a lining better than 0.5 or 0.6. However, you've got a great embryo, the cavity is normal, it's receptive, and it's triple layer. So we're going to go ahead. And many times we've been successful in doing that. Now, sometimes And this is the art of medicine, right? There is the study, and then there is a person in front of you, right? And sometimes you have to think a little bit outside the box and be a little bit brave and a little bit like, I don't really know if this is gonna work, but I just wanna throw everything at you to help you. And this is where we do something a little bit more unconventional treatments, and that's the use of Viagra. There is some studies saying that it might stimulate the lining of the uterus to grow because it's basically a vasodilator, as well as Neupogen, which, to be honest, I don't think anybody really understand how it works, but there have been some studies showing how Neupogen, which is a colony stimulating factor, when you wash it into the uterus through an intrauterine insertion a couple of days before the ovulation day or before you start the progesterone, might have a positive impact in the growth of the lining. So I have used those strategies in situations when everything else has been optimized, and it looks like the thickness of the lining seems to be the prevalent problem.
Awesome. Well, thank you for talking to us about what you do to help with thickening the lining and issues around receptivity. Super, super helpful. So you are extremely thorough. I mean, I honestly can't, this interview has been so chock full of information that I just want to say thank you for being as thorough as you are for your patients. And I can only imagine how much your patients love what you do for them, and how it sounds like you just don't stop at just a negative test. You're going to keep going for them.
I had the benefit of having a doctor that did that for me. So,
yeah. So let's say you've done all of this, and everything is perfect. The receptivity, the lining is beautiful, embryo's gorgeous, it's a day 5 expanded blastocyst, they've done genetic testing. So what next? What else do you do for your patients?
Right. Well, this is where it gets really tricky, isn't it? So at this point, I usually have this conversation with patients, and I basically go through exactly everything that you said. Listen, we've done A, B, and C, and we've kind of a little bit at the end of the road. This is what I call a gun to your head kind of situation where you've done everything. And I say to patients, listen, we can just do it again in exactly the same way, and it could work. And this is always a possibility. There's always a chance that you just basically, it's like, when you throw a dart into the target, sometimes it's your arm, sometimes it's the wind, and other times it's your eyesight, and then you have to have all of that perfectly aligned for you to be able to throw the dart and hit the target. So it's quite possible that we just do everything that we did again, and it's going to work this time. So that's possible. Now, there is also more to the story many times, especially patients that from the very beginning had unexplained infertility, where you're like, I've been telling you for about 3 years that everything is fine, and yes, we're still not there yet. So, initially I thought, okay, maybe it's an egg and sperm interaction, and that wasn't it. And maybe it's an egg quality issue, and that wasn't it, because you've made all these beautiful embryos, and we've gone through all these processes, and now we're here. And this is when I start talking about immune testing. So the impact of the immune system on implantation and fertility is still an area of early research, and it's still a bit controversial. I would think that everybody in the scientific community really recognizes that the immune system plays a huge role in implantation. The part that we can all agree in is, what is the role? How do we test for it, and how do we fix it? And I think it's going to be a lot of years before we have very clear, no doubt sort of answers to those questions. Unfortunately, our patients don't really have all that time. So I have a very honest discussion with the patients about what kind of immune treatments we use at the clinic and what the research is. And I always disclose with them that it is essentially a research basis and that it's not considered the standard of care. But it is something that we have quite a bit of experience in at Markham Fertility Center, and something that we're really proud to offer our patients, because myself included, we've seen a lot of benefits with those treatments.
Great. Can you describe some of the tests to us that you do for your patients?
Yeah, absolutely. It's interesting because we always thought as a scientific community, I mean, an embryo is only part mom. It's mom and dad. So it's certainly a foreign body to the mom's body. So we always sort of thought that the way that an embryo gets by in the body and implants and the immune system doesn't attack it is because the immune system basically it just ignores it. It's like, you're not even there. I don't know you exist. And now we've known that that's not really the case. It's not that the immune system ignores the embryo, it's that the immune system learns to recognize the embryo and learns to say, okay, you belong here. I'm going to leave you alone. So it's that process of learning that the embryo it's meant to be there that sometimes can go wrong and turn the immune system against the embryo and cause implantation and early miscarriages. So we do a series of tests. One of the tests that we do is the thrombophilia testing, which is not necessarily immune per se. That's basically looking at the blood clotting disorders that could have an impact on implantation. Then we look at the natural killer cells in the body. We also look at the cytokine levels. So these are the Th1, Th2 cells. So Th1, Th2 cells ratio are white blood cells, and they are recognizing the Th1 and the Th2, and they basically have a different expression of cytokines. Some of them are inhibitory and some of them are more cytotoxic, and that ratio is important in determining implantation. And we also look at the leukocyte antigen detention test, which is basically looking at what we call blocking antibodies, and those are antibodies that prevent the immune system from recognizing the embryo.
So can we talk a little bit about the Th1, Th2? You know, if there is an imbalance, what kind of treatments do you offer your patients?
So if there is an imbalance, and normally the ratio that we're looking at is steady, with more Th1 than Th2 ratio. If there is an imbalance, there's a number of treatments that can bring that balance right back to normal. So those treatments would be intralipid infusion. And intralipid is basically a concentration of fats that tend to lower inflammation and cytokine ratios. We can also offer IVIG infusion, which is it's a blood product, so there are some risks associated with that, and it's also very expensive. But it is a treatment that has been shown to improve that ratio. We offer sometimes steroids, so dexamethasone or prednisone that you take by mouth, and again that can lower the ratio as well. Sometimes there's a medication called Humira, and this is medication commonly used in people with autoimmune disease like arthritis and psoriasis, but it has been shown as well in the fertility world to lower the Th1, Th2 ratio, which we believe leads to better implantation. So which treatment from those, it really depends on a series of factors and a discussion that I have with the patient.
So once you've done the test and you start the treatment, do you retest before you transfer?
Yes, we do. It really depends a lot on specific situations. So for the most part, yes, we do retest. So if we do Humira, for example, those are 2 injections that we do 2 weeks apart, and then we would retest those levels to make sure it's come down. The same if we do intralipid or steroids, we do tend to have a retest prior to starting the transfer protocol.
And then tell us a little bit about the LAD and the treatment and monitoring.
Right.
I'd love to hear more.
Yeah, so the treatment for that is called LET, or lymphocyte immunotransfusion. It's basically the process of injecting white blood cells from either the partner or really somebody else into the arm for the dendritic cells, which are the cells in the skin, to develop a reaction and bring up those levels of antibodies. It's a procedure that is fairly simple. It's essentially a subcutaneous injection into the arm. It has to be done 2 weeks apart. And then again, prior to proceeding with the embryo transfer, we retest the levels to see that they have come up accordingly. And if they haven't come up, then we do a third treatment. And at that point, sometimes we have to involve a donor, somebody who is not related to the patient, so that there is that stimulation of the immune response and bring those antibodies levels up.
And to be clear, this isn't necessarily approved in every country, right?
No, it isn't. I know in the US it's not approved. But it is very commonly used in England, in Australia, and in Germany. So it is used in other countries, but not in the US.
And do you have any particular predictions for the field of immune diagnostics and
Oh,
treatments?
well, I have dreams. I don't know if predictions.
Oh, tell us your dreams. What are your dreams?
Well, my dream is more research and more money put into this. It's so difficult to do research in this area because patients don't have time for research. So if I'm a patient going through all of these losses, and I know that it's a treatment that can help, and I know that there is, if I have a discussion with my doctor about side effects or not, I might not be willing to be in the placebo arm of the study and, transfer 3 embryos and lose the opportunity completely to be parents. So it's very, very difficult to really do the proper standard of research, which is called a randomized control study, where we have a group of patients saying, you're going to go through all of this, but I'm going to give you a fake treatment, and then we'll see what happens between the 2 groups. So that would be very difficult to do. But nonetheless, there is still tons of research that can be done. So my dream is that after all the advances that we have done in the field of reproductive endocrinology, with being able to do PGS and PGT and PGD and surgeries and all of those things, that we're able to now concentrate in studying the role of the immune system in implantation, do the studies. We are doing those studies at American Fertility Center, but like I said, they take quite a bit of time. So do the studies, publish the data, and make this a standard of care, or make this widely available to many more patients around the world.
Thank you for that. Thank you for sharing all your wisdom for us. We're not done with today's show quite yet. I want to just do a quick recap for everybody. So when your frozen embryo transfer fails, Dr. Garcia took us through 5 steps. So the first one was asking if the embryo was normal, the morphology, and whether it was day 5 or day 6. Talk to your doctor about what that means. Then look at the uterus. Talk about number 3 is whether the cavity was assessed. Number 4, look at the lining, the texture, the thickness. Number 5, the receptivity. Talk about the ERA protocol and how it was done, and then talk to your doctor about immune testing. And so I just want to say thank you for all the wisdom that you shared with us today once again. And if you had one thing, Dr. Garcia, to share with our audience, what would that be?
I would say not to lose hope. Just do not lose hope, and do not let fear stop you from pursuing your dreams. I know it's very easy to feel like this is never going to happen, that it's not meant to be, that you don't deserve this, but you absolutely deserve to be a parent. You absolutely deserve this. And I would say take time for your mental health. Reach out to your friends, reach out to a counselor, reach out to a doctor. Take some time to heal, but do not quit. And I remember sitting in the office of my wonderful friend and mentor, Dr. Vero, telling him that I was done and that I was ready to quit and that I wasn't going to be doing this anymore. This is after my first, I had about 5 IVFs to conceive my second child. And I remember he looking at me and saying, absolutely not. And that was it. He's not a man that talks very much like I do. But he just said, absolutely not. Awesome. And I walked out of that office saying, well, I guess it's absolutely not. So I would just tell patients, and whenever they say to me, how do you do it? I could never do it, and it's too hard. I always sort of say, you don't have a choice. You have to do this. And it's one thing, it's one thing if you sort of decide that the journey is over and that you want to move on. I think that's a very, very valid choice. And I would certainly support any of my patients that want to do that. But you need to do that for the right reasons, and not out of fear, and not out of, thinking that you're not strong enough, because you are. So this is what I would tell any patients going through this. You are strong. You can do this. Do not lose hope, and reach out to all of your resources, and continue to fight for your dreams, because that's the only way to do it.
And find your Dr. Garcia. Find your Dr. Garcia.
There's many wonderful physicians out there.
So for patients in Canada who would love to have you as their doctor, how can they find you?
So I'm at Markham Fertility Center in Markham, Ontario. My website is drmeivysgarcia.com. And the website of the clinic is www.markhamfertilitycenter.com.
Great. And then what about on social media? Are you on social media
Oh, yes,
as well?
I'm on Instagram as well. I'm fairly new to Instagram, but I'm in there. So Dr. Meivys Garcia on Instagram. It's a very fun space, and I love sharing my tips and my stories. I tend to get really mushy in there. So I tend to pour my hair out on those posts. So if you like that kind of stuff.
Yeah. And then if patients want to come to you from the US, do you also treat international patients?
Not really. We tried. So I certainly would listen to a consultation and see what I can help. But generally speaking, especially for the immune treatments, we try to sort of concentrate on patients of our own practice, simply because, you know, it's very hard in fertility to only look at one piece, right? So if I do the immune, but then somebody else is doing a transfer differently, or the embryos, and then it's very difficult to have that fragmented kind of work. So we tend to and it's very time consuming for our staff as well. So we tend to concentrate those treatments for patients of our own practice, but certainly as we get more information and there is more research, and certainly as we publish our own research, then we might be able to expand that program in the future. And I would love to be able to expand that program in the future, but it needs a bit of more work and more care to be able to do it in a way that sort of makes sense when you start working with other clinics.
Yeah, so people should start following you, and if that's something that happens, I'm sure you'll let us know.
Absolutely.
Well, thank you again for being a guest on our show, and thank you everybody for listening in. Please tune in next time, and don't forget to hit subscribe on YouTube and sign up for a class at the Egg Whisperer School. We'll see you guys soon.
Thank you very much for having me.
Bye.
Bye-bye.
Welcome to the Egg Whisperer Show, a program exclusively designed to promote reproductive health awareness and discuss fertility preservation options. Here is your host, the Harvard-educated fertility specialist, Dr. Amy.
She's known as the Egg Whisperer. Fertility expert Dr. Amy Abazadeh.
And you have yet another success story
Just launched by an East Bay fertility doctor.